Okay, perfect. So we are presenting on obsessive compulsive disorders.
All right, so the diagnostic criteria for obsessive compulsive disorder, one, presence of obsessions, compulsions, or both. Obsessions are defined by recurrent or persistent thoughts, urges, or images that are experienced and at some time during the disturbance are seen as intrusive and unwanted, and that in most individuals are caused by marked anxiety and distress. The individual attempts to ignore or suppress thoughts, urges, or images, or neutralize them with some other thought or action by performing a compulsion. Compulsion are defined by repetitive behaviors, so hand washing, ordering, checking, or doing mental acts like praying, counting, repeating words silently. And these feel the individual driven to perform in response to an obsession or according to rules that must be applied rigidly. The behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent, or are clearly excessive. And then to continuing, so these obsessions or compulsions are time consuming. So they take more than 1 hour per day, or they cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The obsessive compulsion symptoms are not attributable to the physiological effects of a substance like a drug of abuse or medication or another medical condition. And all is not better explained by the symptoms anxiety disorder, preoccupation with appearance, as in body dysmorphic disorder, difficulty discarding or parting with possessions, such as hoarding disorder, hair pulling, as in trichotillomania, skin picking, as in excoriation disorder, stereotypes such as its stereotypic movement disorder, ritualized eating behavior like eating disorders, preoccupation with substances or gambling, as in substance-related and addictive disorders, preoccupation with having an illness, as an illness anxiety disorder, sexual urges or fantasies, as in paraphilic disorders, impulses, as in disruptive impulse control, and conduct disorders, guilty ruminations, as in major depressive disorder, thought insertion or delusional preoccupations, as in schizophrenia spectrum, and other psychotic disorders, or repetitive patterns of behavior, as in autism spectrum disorder.
Yes, and something else to note is the ICD-10 code for OCD is going to be F42 point, or just F42, and then if it's predominantly obsessional thoughts or ruminations, it's F42.0, and then for predominantly compulsive acts or obsessional rituals, it's F42.1, and then F42.2 is mixed obsessional thoughts and acts, just for coding for billing purposes.
Some of the common symptom dimensions include cleaning. So it'll be like a contamination obsession. It'll include like cleaning compulsions. It could be like a fear of just getting contaminated yourself or contaminating others. Um, Another one is symmetry. So this is the one that I think most people associate with OCD. So symmetry obsessions, they look like repeating, ordering, and counting compulsions. So doing certain things in order to leave the house or in order to feel safe in one way or another. Another one is forbidden or taboo thoughts. These can be aggressive, they can be sexual, it can be religious obsessions and and relation compulsions. So these can look like guilt. Um, for the religious obsessions, it can be excessive guilt because of maybe not living up to like certain religious expectations. The aggressive ones could be of fear of being aggressive towards others. Sexual ones can also be fear of doing any sexual things to others. Harm is another common symptom to mention. Fears of harm to self or to others and related checking compulsions. So having the fear that you have hurt somebody or that you're going to hurt somebody, you're going to hurt yourself. and constantly having to reassure yourself and checking that you have not hurt somebody or you're not going to hurt yourself, things along those lines.
So for the specifiers, there's with good or fair insight, which is the individual recognizes that the obsessive compulsion disorder beliefs are definitely or probably not true, or they may or may not be true. With poor insight, the individual thinks obsessive compulsive disorder beliefs are probably true. And with absent insight delusional beliefs, these individuals are completely convinced that these beliefs are true. And then specify if tic related, so the individual has a current or past history of a tic disorder. And we'll talk a little bit more about tic disorders later in our presentation.
So the frequency, intensity, and duration, there isn't any specific time that these behaviors have to be present in order to be diagnosed with OCD. Um, but for intensity, has to be to the point that it causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. And we'll talk a little bit more about what that looks like in a minute. Duration, so the onset of symptoms is usually gradual. Um, However, acute onset can occur. Some individuals have an episodic course, and a minority have a deteriorating course, which is when the symptoms just continuously get worse. The frequency. So there isn't like a rule to this either, but one of the examples that were given in the DSM were that obsessions and compulsions occur daily for more than 1 hour per day. So some of those functional consequences. Um, these are just examples of what it could look like. It could look different for other people, but obsessions about harm can make relationships with family and friends feel hazardous, and the result can be avoidance of those relationships. So it can have an impact on people's relationships. Obsessions about symmetry can derail the timely completion of school and work projects because the project never feels just right, potentially resulting in school failure or job loss. Individuals with contamination concerns may avoid doctors' offices and hospitals, um, for example, because of fears of exposure to germs, or develop dermatological problems, skin lesions due to excessive washing. Um, when the disorder starts in childhood or adolescence, individuals may experience developmental difficulties. So these are the forms that it can affect. The effects could be clinically significant.
So the developmental course, obsessions are easier to detect in children, but both children and adults have compulsions and obsessions. The pattern of symptoms in adults can be stable over time, but it is more variable in children. Um, According to the DSM-5 TR, the average age of onset is 19 and a half years. If OCD is untreated, the course is usually chronic, often with waxing and waning symptoms. For some, OCD is episodic, and for a minority, it is deteriorating, as one said. So remission rates without treatment, 20% of adults achieve remission after 40 years. Remission being defined as no longer experiencing the symptoms. With treatment of CBT and SSRIs, 50% of adults reached remission. And then with treatment of CBT, SSRIs, or second generation antipsychotics, 66% of children reached remission. And then the onset in childhood or adolescence has higher rates of lifetime illness, but 30 to 70% will reach remission by adulthood. And in terms of the symptomology, like there is differences in children and adults, which is likely due to the different developmental stages. For example, higher rates of sexual and religious obsessions in adults and adolescents. That's higher in them than in children. And the higher rates of harm obsessions, like fear of catastrophic events such as death or illness to self or loved ones, is more so the case in children and adolescents than in adults. So the prevalence, the 12-month prevalence of OCD in the United States is 1.2%, with a similar prevalence internationally, about 1.1 to 1.8%. And this most commonly affects 18 to 29-year-olds.
Okay, so the risk and prognostic factors. So according to the DSM-5-TR, temperamental factors, so greater externalizing symptoms, higher negative emotionality, so more negative emotions, behavioral inhibition in childhood are also temperamental factors. For environment, there are a lot of environmental factors that play a part in the development of OCD. For example, adverse perinatal events, premature birth, maternal tobacco use during pregnancy, physical and or sexual abuse as a child, and other stressful or traumatic events. Those all increase the likelihood of developing OCD. And then in some children who have developed the sudden onset of some obsessive compulsive disorder symptoms, these have been associated with risk factors such as like various infection agents, and post-infectious autoimmune syndrome. So after they have been sick with a debilitating virus, they have been shown to have some of the same obsessive compulsive disorder symptoms. And then just continuation on that. So these are all genetic prognostic factors. So the rate of OCD among first degree relatives of adults with OCD is approximately 2 times that of first degree relatives compared to those without the disorder. So genetics definitely plays a very big part in the development of OCD. And then also, according to the DSM-5-TR, among the first degree relatives of individuals with the onset of OCD in childhood, the rate is increased tenfold. So developing it in childhood is even more significant than developing it in adulthood. And then the twin studies showed that additive genetic effects account for approximately 40% of the variance in OCD symptoms. So again, genetics plays approximately about 40% of the role in the development of the OCD symptoms. And the estimated heritability of childhood onset was between 45 and 61% for obsessive compulsive disorders in another study we found by Mahjani, Bay, and Burton. And then it is also estimated for adult onset is slightly lower than childhood. So the adult onset in these twin studies showed that if developing it with an adult is 30 to 40% rather than in childhood it was 45 to 61%. So much more likely to develop it as a child if you have a parent or a grandparent that also has OCD as well.
So the gender and sexuality differences, there are male and female differences. Females are about 1.6 times more likely to be affected by OCD than males, and then males are more likely to experience symptoms younger. So 25% have symptoms at the age 10 or younger. And then it's also higher in the LGBTQ plus population. So in a study of 34,392 cisgender college students in Minnesota universities with OCD, they found that 0.9% of heterosexual women reported a diagnosis of OCD in comparison to 4.1% of women identifying as lesbian, 2.8% of women identifying as bisexual, and 1.3% as women identifying as questioning. And then similarly, they found that 0.5% of heterosexual men reporting an OCD diagnosis in comparison to 2.3% of men identifying as gay, 2.1% of men identifying as bisexual, and 0.5% of men identifying as questioning. And this study also found that sexual minorities compared with heterosexuals reported significantly more severe OCD symptoms overall, likely driven by significantly more severe, intrusive, and unacceptable thoughts. And as one said, that symptom dimension can include sexuality, which further kind of like compounds this. In another smaller study of college students comparing rates of OCD in the transgender or non-conforming population versus cisgender people, they found that 4 out of 58 or 6.9% of cisgender college students reported OCD in comparison to 13 out of 58 or 22% of transgender or gender non-conforming